from the Center for eHealth Information Adoption Technology with the Patient Centered Primary Care Collaborative. Welcome to our monthly webinar with today's presentation from Jason Karlawish from the University of Pennsylvania speaking on desktop medicine. Before we get started, a few announcements from the center. I would like and urge you all to register for the PCPCC Spring Summit in Washington, D.C. on March 30th. There are a few slots left. We've expanded our capacity, so there are some slots. If you want to go to the website, www.tcpcc.net, you can go ahead and register and get those remaining slots. Nearly 500 attendees this year at our Spring Summit. Very excited. Dr. Elliot Fisher, notable for the Accountable Care Organization concept, will be speaking as a keynote in the morning, followed up in the afternoon by Dr. Sunny Ramchandani from the Office of Personnel Management, and also Dr. Chet Burrell from CareFirst Blue Cross Blue Shield of Maryland to talk about their medical home initiatives that have gotten accolades across the country. One other announcement is our next webinar for the Center for eHealth Information Adoption Exchange will be on April 14th, and we will be pleased to have Dr. Roger Kessler from Fletcher Allen, who will be speaking about health information technology and behavioral health integration in the patient-centered medical home. And that webinar that we're looking forward to will be co-presented between our center, the Center for eHealth Information Adoption Exchange, and the Center for Behavioral Health Integration into the medical home. So that we'll have a large attendance, and again, will be recorded as this one will be for reviewing and seeing. Just go again to our website, www.pcpcc, after the presentation, and you'll be able to access the webinar and listen at your own convenience. I'm pleased today to welcome Dr. Jason Karlawish. Dr. Karlawish is an Associate Professor of Medicine and Medical Ethics and a Senior Fellow for the Center for Bioethics and the Leonard Davis Institute of Health Economics at the University of Pittsburgh. He serves on the Board of Directors at the Greenwall Foundation, the largest foundation dedicated to supporting research in bioethics. Of interest today is that his current work is examining the clinical and policy implications of how risk is changing concepts of disease, medicine, and aging. I'd actually like to make a comment here of how we came to ask Dr. Karlawish to speak today. Dr. Karlawish published an article, Desktop Medicine in JAMA, November 10th of last year, which has received a lot of attention and really captures, and I urge you to think about it in this sense, really captures the tremendous paradigm shift in the practice of medicine that we're in the midst of getting our arms around and understanding as we go through a transformation. And that's really from an aspect of bedside medicine or symptom-based medicine, disease symptom-based medicine, and moving into this world of population health with the advent of technology that allows us to really accomplish the taking care of a population in a sense of quality and management from a holistic sense across their lifespan as well as for chronic disease management. Many of you who have read the work that's done at Group Health of Puget Sound with Robert Reed, if you've seen those publications on their medical home initiative, you'll notice that one of the many transformative events they did is give their physicians 2 hours a day of desktop medicine time to be at the computer and to look at their population and make outbound calls and coordinate care. So this is an extremely important concept to the patient-centered medical home, both in terms of health information technology as a foundation for the medical home and as to how to best utilize that in this transformation of medicine we're going through. So just before I turn it over to Dr. Karlawish, I would like to point out for each of you attending, if you want to ask questions at any time during the webinar, please enter questions into the question box. And following Dr. Karlawish's presentation, Chris Nordrum, who's the Executive Director here at the Center, will be posing those questions for Dr. Karlawish to answer. And we have a total of an hour and a half dedicated to this presentation. So we'll see how the questions start coming once we get there. So with no further ado, I'd like to turn it over to Dr. Karlawish. Welcome, and we're looking forward to hearing what you have to say and to seeing your presentation. Dr. Karlawish.
Well, thank you. Thank you, Dr. Nath. Thank you. It's a pleasure to be here. And I also want to thank Lauren Vandergrift, the moderator, and Chris Norton for organizing this, and thank you all for inviting me to speak. I will admit that the venue is a little unusual for me. I've done one or two webinars in the past, but not as much as I've, say, done talking face-to-face. So I'll just put that out there. I do look forward to answering your questions at the end. As Dr. May said, I am a physician. I'm trained in internal medicine and then did additional board training in geriatric medicine. And my research has been largely in areas related to ethical, legal, and social issues in the care of older adults, particularly those with cognitive impairment. And later on, I think I'll bring out how that work sort of got me into thinking about how risk is transforming medicine. So it's a real pleasure.
Welcome to GoToWebinar, web events made easy.
Slide, you'll see my email, and you're all welcome. If later on you want to email me questions or comments, please do. So I have it there. I'm going to advance the slides, but I have to just get the computer going here. Hang on just a minute. Okay, good. Oh. All right. Before I go into my remarks, I just want to acknowledge some support and also some disclosures. This work has been made possible by two grants. One is the Robert Wood Johnson Foundation Investigator Award in Health Policy Research, and the other is the philanthropic grant from the Marion S. Ware Alzheimer's Program, given to myself and some other colleagues at the University of Pennsylvania. By way of disclosure, I am a member of the Professional Advisory Board of Senior Bridge, Inc., which is a company that sells care management. And I do have shares in Senior Bridge. I don't think that any of those the concepts of care management are going to come up in any substance during the course of my talks today. And as Dr. Nace mentioned to you, what I'll be talking about today is essentially expanding on and spending a bit more time on and developing and taking some risks really on remarks and ideas that I introduced in this paper that came out last November in JAMA called Desktop Medicine. And I encourage you all certainly to go and have a look at the paper afterwards. I will admit that I think some of the ideas in the paper are a bit telescopic, in large part, frankly, to keep within the strict word and space limits that medical journals are increasingly imposing on publications that are not randomized controlled trials. So let me tell you what I mean when I say desktop medicine. And I think you're going to find over the course of our remarks that I'm going to spend very little time actually discussing the concepts of the medical home or health information technology themselves. But I trust that you all, the audience, will see how the idea of desktop medicine really kind of establishes a conceptual framework for thinking about the medical home and information technology. And I really, at the end, will make some specific remarks, particularly around health information technology. I do want to say that I think that I'm often suspicious of people who feature conceptual frameworks and theories and kind of ignore the evidence. I think the two need to talk to each other. Having said that, I do think that a lot of the discussions around the medical home and the need for an electronic medical record, et cetera, have been overly dominated by issues of economics and efficiencies and costs, and really haven't paid attention to, I think, some fundamental issues about what is medicine and the practice of medicine. And that's, I think, where my talk is going to be going. This is an image of a physician and a patient and a grieving family member. This is a classic image of bedside medicine. That is to say, a sick patient at the bedside, here a rather crude bedside constructed by two chairs and a pillow, and the physician seated at the bedside, interviewing, examining, talking to the patient, and trying to therefore come up with what's the cause of the symptoms and signs, that's to say the pathology, and then to recommend a treatment. And I realize that's a wonderfully antiquated image, but it's an image that was and still I think is very much alive in medicine, as represented here by another physician at the bedside. In this case, this is William Osler, Sir William Osler, one of the wards at Johns Hopkins Hospital in Baltimore. And again, he is conducting a bedside history and physical. There he is at the bedside, going to the bedside to practice bedside medicine. And I want to talk a bit about what we mean when we say bedside medicine. It's a concept of medicine that starts with the notion that a physician and patient meet each other. The chief complaint or chief concern is a new term I've heard, but I grew up in the chief complaint era. I graduated med school in 1991. The chief complaint motivates a history and then a physical, and then the acts of clinical pathologic correlation to decide what pathology explains the data that have been gathered by that history and physical, and then feeding that information, disclosing it back to the patient, and coming up with a treatment plan. Indeed, this idea of the bedside medicine so resonates in medicine that, when we trained, we were told, go to the bedside. That was where you went to learn medicine. Bedside rounds were a core feature, an essential feature of medical training. In this space, the bedside really, I think, has come to capture not simply where we diagnose and treat patients, but also where we discover the diseases that patients have. And so it's this very resonant concept for capturing just both medical research and the discovery of diseases over the 20th century, 19th into the 20th century, and then also where doctors and patients meet. Doctors take care of patients. Well, what I want to posit is that a new concept of disease has entered into medicine. And out of that new concept of disease, what follows is a new model of medicine. The bedside concept of disease, again, is a pathology in an individual, and that pathology is discovered by clinical pathologic correlation, using in particular the techniques of the history and the physical exam. Well, what is this new concept of disease, this concept of desktop diseases? Well, what I'm going to do is lay out for you how we discover these desktop diseases. And what on this slide I'm depicting here is the steps. First, longitudinal epidemiologic data shows that some factor is associated with the risk of a negative health event. So, for example, elevated blood pressure. Beginning in the 20th century, it was not medicine, but actually the insurance industry that began to notice that when they looked at blood pressure over time in mostly men, which is who were buying policies for life insurance, that blood pressure was a wonderful, keen predictor of the likelihood that a man would die. And the actuaries, the insurance salesmen, started to use blood pressure, the results of insurance physical, to decide whether, and if so, how much they would sell a policy to a man. And so this is, just a side note, it's quite interesting that the history of hypertension began not with medicine, really, in some sense, but actually began with the insurance industry. Well, that kind of descriptive data is all very well, and I don't think the insurance industry, quite frankly, cared whether there was anything causal going on there. All they had was, from an actuarial perspective, a wonderful predictor of whether someone would die. Well, the next step in the discovery of desktop disease is to say, well, what if I did an experiment? And the experiment was designed to test whether an intervention on the factor will reduce the likelihood of the negative health event that we don't desire. So in other words, a randomized controlled trial, which is a form of experiment, is performed. And if that trial shows that people who get the intervention compared to people who don't are less likely to suffer the negative health event, the next step is that factor becomes redefined as a disease. And I remember very distinctly in my own training when I was in residency, in my internship, the systolic blood pressure in an older adult up to 180, 190 was part of normal aging or the physiologic response to the heart aging vasculatry. And it was untreated because it was not a disease, because it was part of normal aging, part of the vascular response to hardened arteries. Well, overnight, the systolic hypertension in elderly persons trial transformed systolic hypertension in elderly persons into a disease because the intervention of chlorothalidone upon older adults reduced their systolic pressure and reduced the probability of them having heart failure or stroke. And I remember distinctly going from my internship where I would measure blood pressure in older adults and send them out saying that was part of normal aging or whatever. And a year later, I was prescribing chlorothalidone and other antihypertensives to those same patients. Overnight transformation into a desktop disease. So I've already said this before, but this slide here just simply operationalizes those conceptual points. For example, the Framingham Heart Study here shows an association between systolic hypertension and cardiovascular disease in the elderly. The SHEP trial shows that if you give chlorothalidone in a randomized controlled design, you reduce the incidence of stroke and other coronary events. And so now systolic hypertension in elderly is transformed from an inevitable part of aging into a treatable disease, just like that, overnight. This slide here is an attempt to summarize on a table what are some common desktop diseases and to capture that conceptual framework that I've talked about for each of them. So I talked about hypertension, but the first line I have there is dyslipemia. And you can now go to a website, I'll show you later, called the National Cholesterol Education Project, NCEP. And there is an online tool that you enter information about your patient. And out from that information, you get back the probability that patient will suffer a major coronary vascular event in 10 years. Another key feature of the desktop diseases is that they rely upon having some sort of discrete clinical event, is what I call, that is the sort of, if the risk happens, it is this discrete clinical event. And in the case of dyslipemia, it's stroke or MI. Same thing with hypertension. And finally, a third feature is this intervention to validate the link between the diagnostic tool and the discrete clinical event. And in this case, for example, with hypertension, I already talked about thiazide, the beta blocker, and dyslipemia, statin drugs were the breakthrough for the discovery of dyslipemia as a disease. I also have osteoporosis here, where bisphosphonates were key for the discovery that bone mineral density, when normed to a 30-year-old, defines the disease called osteoporosis. And the bone fracture is the discrete clinical event we're looking to prevent. I'll talk later about the FRAX website. And then finally, I have diabetes down here, where again, the intervention of an agent such as insulin upon a glucose level, in this case represented by the hemoglobin A1C, is used to represent the reduction of the risk of someone developing diabetes. Diabetes defined in the clinical syndrome as polyuria, polydipsia, etc. So the common theme of these diseases are this notion of a discrete clinical event that is predicted by some risk factors using a diagnostic tool, and that an intervention has validated the link, the causal link between that diagnostic tool and the discrete clinical event. Now, hang on a minute. Don't want to do it that way. I'm going to do it this way. Sorry about that. So these diseases are prevalent. I have here a slide which summarizes what percent of in the United States the population has hypertension and other forms of these desktop diseases. And you can see they occupy as many as nearly half of the United States population has these diseases. And these diseases are morbid. Here's a list of the top 15 causes of death as of 2006. And you can see here that several of the leading causes of death are desktop diseases: heart disease, cerebrovascular disease, diabetes. I should also point out how desktop medicine has begun to transform diseases that were traditionally bedside into desktop diseases. And I'll talk about that in a moment when I talk about Alzheimer's disease. In addition, though, at this point, I'd like to simply say the concepts of risk and risk reduction and thinking of disease as risk really have begun to occupy even when we think about traditional bedside diseases. A good example might be someone develops, say, ulcerative colitis, inflammatory bowel disease, and after being treated for that very symptomatic condition, enters into years of monitoring for the risk of colonic cancer. Concepts of risk have spread widely beyond simply desktop diseases, but also into bedside diseases. So this is what I grew up with, not with this gentleman in particular, but I trained in the bedside era. That's how I learned medicine. I remember my first years in medical school with, the chief complaint guided history and physical. That was that was our lingua franca and our key skill to learn. Go to the bedside. And I would argue now medicine has changed. I believe that we are in a new model of medicine, and the model here that I call bedside medicine. And I found this journal online, and I'm fascinated by it, called Medical Economics. This isn't precisely the image I wanted to capture, but I think this whole image it captures a lot of things, namely medical economics, smarter business, better patient care. Here's a physician here in business casual and the outpatient setting, not exactly the desktop, but the desktop that he would be at is where the computer sits with its own desktop, where large longitudinal databases are analyzed, where patient medical records are looked at, where online risk calculators are accessed, all of which allow that person to either, as a researcher, discover new diseases. We'll talk more about that in a minute, such as the discovery of Alzheimer's disease as a desktop disease, and or diagnose patients who have desktop diseases and or treat them. This is the image I think think, that captures this new model of medicine. And again, I use this term desktop because the desktop is the space where doctors and patients meet. It's also the space where the computer sits, which is such an essential technology to the development of desktop medicine. Just as the stethoscope was so key to developing bedside medicine, the computer has been so key to developing desktop medicine. The ability to access large and longitudinal databases, analyze that data quickly, and represent it clearly and efficiently has, I think, been probably the most instrumental technology to make the discovery of new diseases possible and their diagnosis and treatment. And I personally certainly can witness that in my own years, where I went from working with paper charts, et cetera, to now, of course, sitting in front of a computer with Epic as my new chart. And also, obviously, my colleagues and myself looking at large databases to discover the biomarkers of disease. Here's some examples of desktop diagnostic tools. This is the FRAX criteria, the website, WHO Fracture Risk Assessment Tool. You can Google FRAX and put it in the search engine. You'll go to this website, and you'll see here that you access a web page with a very easy point and click and fill in information: age, date of birth, gender, etc., bone mineral density. Click on Calculate, and you get back the person's probability over the next 10 years of developing a major osteoporotic fracture or a hip fracture. So you have engaged in, after gathering these data from your patient, their gender, their weight, their height, etc., after getting a T-score measurement, you then enter these data and get back your risk assessment. And then you engage in what I call not clinical pathologic correlation, which is the bedside model of a diagnostic exercise, but you engage in what I call clinical actuarial correlation, which is the simultaneous diagnostic and treatment exercise. That is to say, does this person have an actuarial probability of a bad event that's sufficiently high that I should intervene and treat them? And in this case here, we see the actuarial probability of developing a fracture over 10 years. So unlike clinical pathologic correlation, what is the pathology that explains this individual's signs and symptoms, clinical actuarial correlation is the activity that defines whether this person is at risk, and if they are at risk, is it sufficiently large that I should treat it? You can go to a search engine and type in National Cholesterol Education Program, NCEP, and you'll find this calculator where you, again, gather your data about your patient. In this case, some clinical information: what's your age and gender, and do you smoke, but also some measured information: cholesterol and systolic pressure. And again, hit the button, and you get back 10-year risk of developing a heart attack. And again, now you engage in the clinical actuarial exercise of deciding whether or not to recommend treatment for your patient. I've mentioned diabetes, and this is a photograph from 12th and Market Street in my hometown here, Philadelphia. And this is an advertisement on a bus kiosk. It might not be possible to read it, but what this is an ad of is a ambulance that's crashed through the living room of Hank. There's Hank and his wife, or someone else, and it says on the side of the ambulance, "Hank, diabetes complications are coming to get you." Below that is the advertisement line, "Know your risk, know your A1C, diabetesaonc.org." I've seen these ads throughout Philadelphia and in some airports and whatnot. And I think this nicely captures how these concepts of biomarkers, risk factors, stand for the disease, need to be assessed and monitored, represent the risk of something bad, and are very translatable into easily accessed and communicable messages. I mean, this is a bus kiosk ad on a major street in Philadelphia. In my field, the disease I do spend a lot of time in as a clinician and a researcher is Alzheimer's disease. And I remember when I finished my fellowship at the University of Chicago in geriatric medicine, Alzheimer's disease was a bedside diagnosis. You got a history, you got a physical, you engaged in clinical pathological correlation, and based on that, you decided that the person did or did not have Alzheimer's disease. In the last 10 years, I have lived and witnessed, with my colleagues who do research in Alzheimer's, the transformation of Alzheimer's disease into a desktop diagnosis. And key to that transformation has been this concept of biomarker. And if there's one sort of side message or message I want to put out here is the word biomarker, I think, captures a lot about what this new model of medicine. And it's a term I think we need to think more thoughtfully about. I'm not going to devote more time to that point, but simply on this slide to illustrate how, since about 1995, you see this alarming increase, alarming, I reject that word, you just see this increase in this linkage of this concept of Alzheimer's with biomarker. And what's going on here, of course, is a very concerted effort in the research community to identify the risk factors, if you will, the things that say that someone is going to develop clinical Alzheimer's disease. And indeed, what Alzheimer's disease right now, as I'm talking to you, is experiencing is the creation of notions of preclinical Alzheimer's disease. That is to say, by measuring a biomarker or some combination of biomarkers or other risk factors, you would say that this person has Alzheimer's disease because they are at risk over time of developing disabling cognitive impairment. Now, of course, what the field lacks at this point is that key result from a validation study, namely a randomized controlled trial that shows intervention reduces risk. But once that occurs, much like in the histories of hypertension, osteoporosis, and dyslipidemia, we will see Alzheimer's disease transform from a bedside diagnosis into a desktop diagnosis. And again, back to technology, these events would not be possible, and you can see here with the chronology on the x-axis, if in the last 10, 15 years we hadn't had tremendous advances in computational sciences that allowed large databases to be analyzed quickly, as well as in large transformations in our ability to analyze enormous amounts of protein and related data in an automated fashion, reducing what could be months, if not years, of lab time to essentially the push of a button by a machine. So, what are some consequences of desktop diseases? Well, I think I have tried to make the point to you that drugs are critical for the discovery of disease. For the discovery of disease. I've italicized that word because I think many of us, myself, came out of an era where drugs are about treatment. We have drugs because that's what we do to treat patients. But one of the points I want to make here is the critical role of pharmaceutical products, of drugs, not simply to say to treat someone, but as part of an experimental validation that something is a disease. So suddenly the drug becomes wrapped up in the very concept of disease. Disease becomes, ultimately though, in a desktop model, the result of a multivariate risk calculation. Let me go back to osteoporosis. I remember when the T-score began to define what is osteoporosis. One measure, that defined the disease. But I showed you the FRAX website, and what you should see from that website is it's not just the T-score that you enter. You also enter several other factors, descriptors about your patient, gender, glucocorticoid use, etc. You hit a button, and all those factors are put together in a multivariate model to produce the calculated risk. And so in the history of these diseases, what I've noticed as I've explored that is they start out typically as a very simple biomarker definition, T-score. But over time, because the goal is to accurately define people's risk, we realize that the biomarker is only one way, and certainly, well, and an imperfect way to find risk. And you start to see the biomarker equal disease concept to fade, and instead the disease becomes a multivariate risk calculation. And I think FRAX and NCEP stand as excellent examples of transformation. It's not just in the case of cholesterol, your good and your bad levels, but as you can see from the NCEP website, your gender, your systolic pressure, your smoking habits, etc., that collectively define whether or not you have a disease. Which takes me to my third bullet, that you begin to see once you start to think about a desktop disease, this dimensional construct. The category of the idea of disease as a category really makes little sense. That is to say that someone does or doesn't have a disease when it's defined along a continuum of risk is an arbitrary distinction along a continuum. What also follows from that is that the traditional categories of prevention that many of us have been sort of trained within and talk about, namely primary, secondary, and tertiary, frankly make little sense. They become sort of arbitrary cut points on the basis of things like whether someone ever had a sign or symptom, or how much risk they're at to say that therefore that goes from primary to secondary. If it's a continuum, once you start drawing cuts along a continuum, you generally are entering into sort of, frankly, arbitrary cuts. And I have certainly seen and been reading several essays where the argument is made that it no longer makes sense to speak about primary, secondary, and tertiary prevention. I think a final point about the consequences of desktop disease that I want to put out there is one that I've hinted at from when I talked about systolic hypertension in an elderly person. And that is that the sort of prevalence of these diseases becomes very unstable. Because if disease now is defined along a continuum, subtle shifts in those continuums can dramatically change the proportion of people that are judged to be in need of treatment. We've seen this over time in the history of lipids, for example, where changes in what are considered the cutoffs for the lipids suddenly expand dramatically certain groups by age and gender, proportion of whether or not they should be, quote, treated for their hyperlipidemia. My example of systolic hypertension was another one. I remember by the time I became a geriatrics fellow, about 80% of my patients in my clinic, my practice, were on antihypertensives. And had I been taking care of them 5-10 years earlier, it would have been a fraction of those patients. That's unusual in the traditional way we think about disease, which occupies kind of a more natural sort of pace and chronology. Instead, it almost has kind of a behavior like almost the way economic phenomena can occur, where all of a sudden there are these spikes that occur in events because of a whole host of multivariate events leading to suddenly an uptick or downtick in interest rates or unemployment. I realize that's a funny metaphor, but I think it helps to express how this is a very different phenomena underlying how the prevalence of disease is determined in the desktop model compared to the bedside model. On this table here, I've just simply summed up the distinction between the bedside model, where disease is pathology in an individual, typically identified by signs and symptoms, and I've given you some classic examples. Congestive heart failure is, I think, a great one. Dyspnea, orthopnea, PND, RALS, S3, edema. Does the person have CHF or not? Versus the desktop model, which is disease as a risk of future impairment in an individual, and I've listed out some examples there. I've noticed, for example, that in the case of heart failure, there is now a concept of stage A heart failure, which describes being, quote, a high risk for heart failure. I should also note that I've noticed now in my own practice how heart failure is being more and more conceptualized on the basis of the biomarkers of heart failure, more so than the symptoms of heart failure. So, for example, when I round on the wards, and I don't mean to sound like grumpy old Doc Karlowish, I'll plainly confess I'm 44 years old. Whether that's old or young, I'll leave it to you to decide, but it's somewhere in the middle maybe. And I notice more and more that when I'm presented a case of heart failure, the emphasis is not so much on orthopnea, RALS, PND, S3, and edema, but more on what the BNP level is and whether that really means the person is or isn't in heart failure. I talked about the diagnostic exercise, and this just simply sums that up here. Namely, in the bedside model, we have the H&P driven by the chief complaint, whereas in the desktop model, we have this idea of running the numbers to come up with an active clinical actuarial correlation to decide whether a person's risk is sufficiently high that they would warrant treatment. Let me talk a bit about some of the controversies and now the practice of deskside medicine. I've spent a lot of time on the concept of desktop medicine, excuse me. I spent a lot of time on the concept of desktop medicine. Now I want to talk about putting it into practice. And one concept that I found out there in the literature is this idea of clinical inertia, which is the recognition of the problem, if you will, like hypertension or diabetes not in control, but the failure to act, to treat. And I have here a slide that just simply sums up the proportion of patients in some studies that have been shown to be not treated at the who had these desktop diseases. And the point by the authors here that while the difficulties in managing asymptomatic patients are understandable, they don't mitigate the need to improve care for disorders such as hypertension, dyslipidemia, and diabetes. Actually, Dr. Phillips, here, the lead author of this paper on clinical inertia, has been a leader in advancing this notion of running the numbers first, which his argument is that we should deal with blood pressure and glucose before talking about other problems. It's our responsibility to help patients appreciate the importance of such disorders as hypertension and diabetes, he writes. I'll talk later about this idea of appreciation and risk, but for now what I want to focus on is what struck me about this debate about clinical inertia, and it is a fierce debate, is fundamentally a debate about what's the position of the chief complaint in the doctor-patient encounter, where Dr. Phillips here is essentially arguing that the chief complaint is no longer that act which should initiate the doctor-patient encounter, but instead we should, quote, run the numbers first and deal with those issues and then turn to the chief complaint. In response, their work has generated fairly vocal criticisms. Running the numbers first, Drs. Boyd and Leff wrote, does not adequately acknowledge a patient-centered perspective of chronic illness care. Drs. V. John Hayward and Ubel wrote, the paradigm of running the numbers first is at odds with the fundamental principles of primary care interactions. Physicians would be imposing their own priorities onto patients. I do not intend to take a stance on whether I think that we should run the numbers first or not, but I do think that those of you who are in the vanguard of practicing desktop medicine, and I do think, for example, the patient medical home is a place where that will be occurring, need to think very thoughtfully about this debate going on about whether to run the numbers first or not. Dr. Phillips and colleagues have written about other criticisms of the bedside approach to care of patients. So one criticism I've told you about already was that the chief complaint, organized clinical encounter, distracts from the ability to take care of desktop diseases. Another complaint they've made is that what's called evidence-based paralysis, which is the failure to act in the absence of specific trial-based information. Another sort of somewhat provocative phrase they use is RCT myopia, which is the belief that randomized and controlled trials are the only justification for clinical action. I spent a little time developing this point. It's a bit complex, but bear with me. What's going on, I think, is a new paradigm for how to think about treating diseases. I'm still pondering this, so I'm going to just lay this out as, if you will, the facts, ma'am, and not make a statement about whether I agree or disagree. But the argument is here is that physicians and patients should make decisions based on the, quote, best available evidence, including cell and animal studies, observational studies, and controlled trials if available. And the strengths and weaknesses of the findings with each approach should be given due consideration. It's a view that recognizes that if risk is a continuum described by a variety of data, remember going back to the Framingham Heart Study and the results of clinical trials intervening on that risk factor, and pathologic studies and animal models that show the relationship between the risk factor and pathology. With the strength of all that evidence, the argument is made, the RCT no longer can simply be the guidance for whether you should treat a particular patient based on whether they meet the eligibility criteria for the clinical trial. Because risk is the continuum, and people on either side of that continuum who weren't necessarily eligible for the clinical trial, it arguably becomes odd to say, I won't treat them because they don't perfectly meet the criteria for my clinical trial. This debate has been played out with the National Cholesterol Education Program. In their last set of guidelines for cholesterol treatment, they recommended that women at high risk of cardiovascular events should be treated, even though there was no specific clinical trial evidence. And they were called out on this by a group. Said, you don't have clinical trial data that show that that group of people benefit from statin and from drug therapy. And it is inappropriate and violates the tenet of evidence-based medicine to recommend that. And NCEP wrote in response that their approach is to review the entire body of scientific evidence, including animal pathologic, genetic, and epidemiological studies, and clinical trials. And based on that, they get a compendious, if you will, sense of all of the data of how to intervene and reduce risk, such that they felt comfortable saying that the data supported treating women at high risk of cardiovascular events. It is interesting that their argument also engaged, frankly, what I think is a policy or political point, which is the second line here, that the alternative approach, they argued, would mean that the alternative approach being to wait for a clinical trial that involved women at high risk of cardiac events. That if they chose that strategy and demanded that level of that kind of evidence, that would mean that many women would have a potentially preventable heart attack before they're recorded the benefits of therapy. I think that the NCEP controversy and the earlier slides I showed you over the issues related to RCT myopia are capturing, I think, a fundamental epistemologic debate in medicine about what kind of evidence should warrant intervening in what kind of patient to reduce their risk. And I think that there is beginning to be a questioning of the evidence-based paradigm of the clinical trial is the gold standard with which we guide our decisions about making recommendations for risk reduction. So to summarize, the bedside model of treatment approaches treatment by the exercise of clinical judgment, with the preeminence of the results of randomized and controlled trials to select the best treatments for the pathology and to relieve the patient's symptoms as well as possible. In contrast, the desktop model of medicine really emphasizes what I call clinical actuarial correlation. It integrates the patient's measured risk with the results of biological and cohort studies and clinical trial data to determine the value of reducing that patient's risk. It becomes much more, frankly, I think, almost akin to an economic way of thinking about who's at risk and whether to intervene. Well, what are some consequences of this desktop practice that I've been talking about? Well, first, I think that the preeminence of the chief complaint, or the editor's gem insisted I change that to chief concern, but that the preeminence of the chief complaint to organize the medical encounter diminishes. And the H&P is replaced by, or if you will, stands beside this idea of running the numbers. And also that the preeminence of the randomized and controlled trials as the mechanism, the pathway with which you determine therapy, is diminished. And instead, diagnosis and treatment become a sort of actuarial exercise. And I've actually begun to look into a term that's out there in the literature now, I've noticed, mostly in the industry literature, called theragnostics, which combines the concepts of therapy and diagnostics into one word, theragnostics. We move on now to speaking about medical education. If we're talking about a model of medicine, desktop medicine, and its implications for treatment, and its implications for practice, physician's practice, what are its implications for how we should educate doctors? This is a busy slide. It's a tough slide. But what it's simply showing is the key thing is on the column that starts out with the header correct, below it are a series of percentages. And these are the percent correct answers of knowledge-based questions about biostatistics that were asked of medical residents. And what I think you can see is that no percent really kind of goes above the high 50s for these 16-odd questions or so about various statistical concepts. If we're talking about diseases risk, we're talking about the activity of clinical actuarial correlation, diseases numbers. These are frightening data. I mean, these are the kind of data that would, back in the days when Flexner was traveling around America, cause people to be upset about medical education with respect to understanding the sciences of biology, biochemistry, chemistry, et cetera. Well, here we have data showing the ability of physicians in training to understand the core sciences of desktop medicine. Not too good. I put this slide in to be very provocative. This is a slide that depicts the decline in the proportion of third-year internal medicine residents intending to pursue a career in general internal medicine. I put it in here because it's dropping. If you follow the line, it looks like by about 2000 and now, I guess, there'll be no one going into general internal medicine. You can show the same slide for family medicine. Those are two fields that I think are at the forefront of desktop medicine, although I do think desktop medicine has essentially occupied most of medicine, even, for example, surgery. I've been working with a surgeon who's been reviewing how risk is influencing the way surgeons treat, concepts of risk and surgical interventions as risk management. The point here being that I think that one of the reasons maybe why general internal medicine is experiencing this just precipitous decline is we still admit into medical school and train in medical school and educate physicians under a bedside model. And you look at a field that's at the forefront of desktop medicine in terms of the care of these patients. Well, no wonder people don't want to go into it. Now, I know there are other issues about reimbursement, about the amount of time physicians have to take care of patients. I know that. I did general geriatrics. But I do think that I can confess personally that one of the reasons why I went into geriatrics, and in particular into cognitive disorders, was because it allowed me to more practice what I liked, which was a bedside practice, because I was kind of trained in a bedside model of medicine. I remember in medical school the very distinct disdain with which physicians discuss statistics and probability issues, the very disdain with which they discuss the notion of disease as an economic problem or an economic model for disease. I'm not saying they were right or they were wrong. I'm saying if you're raised in that kind of mindset, you're going to gravitate towards fields where you can practice that kind of medicine. I think that a gap exists now between the reality of desktop diseases and how we select our physicians and how we train them. And I think we need to, and I'm not saying some things here are not deeply original. I think that you can look over the last 10, 20, 30 years, there have been repeated criticisms of medical education requiring things like physics and biochemistry to get into medical school, and then how we train students once they're in medical school. But the one contribution like to make to that debate is that this change needs to occur because of a fundamental change in the nature of disease. And so we need to better select people who are going to be interested in wanting to practice desktop medicine. So I'd like to begin to start to say, well, maybe pre-medical requirements should more look at nurturing people who have interest in and areas such as psychology, economics, biostatistics, that, if you will, the more desktop-focused sciences compared to the standard model of the biochemistry major who's taken physics. So I summed up here kind of on the bedside model, what were the classic sciences of bedside medicine: anatomy, biology, biochemistry, histology, etc. And over on the other side, what are the classic sciences that I think are necessary to discover and diagnose and treat desktop diseases? And I would argue that the laboratory sciences are more oriented towards biomarker discovery and these kind of fusion fields like genomics, and also sciences of economics, epidemiology, information sciences, psychology, statistics. Wouldn't it be interesting if a medical school suddenly started to say, requirements to get into our med school are that you show adequate understanding of univariate statistics, at least one semester of economics, and psychology of decision making, and a little bit of chemistry. I think we would start to see very different kinds of doctors come out if they came in with those kind of training. All right, a little bit more about desktop medicine in practice. Think about how we talk about disease under the bedside versus the desktop model. In the bedside model, disease is a categorical entity. I have osteoporosis, or I don't have osteoporosis. I have Alzheimer's disease, or I don't have Alzheimer's disease. But in desktop diseases, as you saw when I gave you the example of the Frax criteria, for example, the diseases are dimensional. And so you don't really come out saying, I have osteoporosis, but I have a 1.9% chance of a major osteoporotic fracture over whatever period of time. I think there are enormous implications for thinking about disease in this way for how we communicate with patients and make decisions with patients. Let me talk about that. We're back quiet again. Let me talk about that. So this is a fabulous paper that actually has since been published. It was in Genetics and Medicine. On my screen, it's slightly cut off the reference. But the paper is called, I Know What You Told Me, but This Is What I Think: Perceived Risk of Alzheimer's Disease Among Individuals Who Accurately Recall Their Genetics-Based Risk Estimate. So what this study did was interview 158 people who were part of a study looking at whether people want to learn their genetic risk of developing Alzheimer's disease by measuring their ApoE genotype. What they did was they disclosed to some of these people their ApoE results and what their risk, therefore, was of developing Alzheimer's disease. These were asymptomatic, cognitively normal people with a family history of Alzheimer's disease. Okay, so the cognitive issues don't enter into this at all. Right? That's important to emphasize. These are people who have a family member with Alzheimer's, but they themselves are cognitively normal. What they discovered was that there was a fraction of people who, although they could tell you what their calculated Alzheimer's disease risk was, in other words, they could say back, you told me it was 60%. They, though, when they were asked, what do you think your risk is, came back with a number that was at least 5% or more points different from their calculated Alzheimer's risk. About half the people did this. Okay? In other words, I know what you told me, but this is what I think. This study, I think you could repeat it across any number of diseases where we hand the individual what we say is their disease, their risk, but then they take that number and appreciate it in a very different way. And the purpose of my talk today is not to unpack the psychology of what's going on there, but to say that that is, I think, one of the areas of desktop medicine in practice, basic science, that we need to aggressively pursue. Why is it that people see risks differently than what we say they are? I'm not saying that's wrong. I'm not saying that it's right. But why does it happen? How does it happen? And how could we intervene on that if we think we should intervene on that? By the way, I know these people who wrote this paper very well. I'm part of the project. And it's interesting, in the paper they talk about this, but they've told me also anecdotally, it's absolutely fascinating to hear people explain things like, well, I know, you said I have ApoE4 and I have this 60% risk, but my dad's the one that had Alzheimer's, and, I look like my mom, I don't look anything like my dad, so I think I probably have a reduced risk, et cetera. And before you say that this result simply reflects that people, quote, aren't very smart, okay, Sergey Brin, who is, I think, I always get these guys confused. I think he either owns Google or one of the other big companies. Sergey Brin found out he has one of the genes that puts them at risk for developing Parkinson's disease. And he knows what his risk is. He'll tell you it. He also drinks green tea, joined a diving class. He has a diving coach, and he dives into the water. And a couple other activities, and he tells you how each of those activities reduce his risk. And he has calculated what his risk is now based on these various lifestyle modifications he's made. Whether Sergey Brin is right or wrong is not the issue. The point is that the guy is smart enough to develop and lead one of the leading IT companies in the world is in some sense telling you, I know what you told me, but this is what I think. Another aspect of putting desktop medicine into practice is we're talking about treatments for diseases that are not episodic treatments. The classic paradigm of that being, antibiotics for an infection. Okay, we're talking about treatments that are essentially, well, quite frankly, some say phrases like for life. But anyone who's practiced care of these patients knows very well about the challenges of compliance, of keeping people on their risk-reducing interventions. And what I've shown here is just simply a summary slide across a variety of different treatment modalities of what the proportions of compliance are over time. And as you can see here, they're not that good. There's a popular study that was in JAMA a few years ago of the compliance or adherence with lipid-lowering drugs after an MI. And within 6 months, I believe about 2/3 of the patients were no longer on their lipid-lowering drug. These are people who had had a symptomatic classic bedside event, namely an MI, but then entered into years of risk reduction. So I'm not describing a problem that there's no new discovery on this slide part. This is me putting up very well-known information. But what I think is new is this: how to get people to adhere to their medications. And I think this is going to be one of the other new challenges in desktop medicine, namely taking advantage of how people think about risk, namely the problem being that risk is about a long-term event, and most of us, frankly, are very present biased. We can talk about things that we're worried about in the future, but we tend to live in the present. And colleagues at Penn and elsewhere have discovered the application of behavioral techniques to try and get people to think about or feel their risks differently. So what this slide is a bit of a complex results of a clinical trial that took patients who were on Coumadin and essentially said, if you can keep your INR within range, we'll enroll you in a lottery. Excuse me, you'll be enrolled in a lottery, and if your INR is within range and you win the lottery, you can win money. If your INR is not in range and you win the lottery, we'll tell you you could have won it, but you won't get the money. And they obviously had a control group who weren't enrolled in a lottery. They were just charged by usual means to maintain their INR. And I think what you can see here on the far left is that people who got that lottery control group, were more likely than people in the control group to have their INR within range, particularly as a subgroup analysis in the middle if they were people who had had their INR out of range at baseline. So in other words, people were having trouble with compliance with their Coumadin and keeping within the range of their INR when they were enrolled in a lottery-based mechanism that rewarded them for achieving their goal with money, that they were more likely than people in the usual treatment group to achieve an INR in range. This approach to treatment is totally new. I don't remember my training being told, if your patient's not having success with compliance, enroll them in a lottery, where if they achieve their goal, they'll have a chance to win money, or forget the lottery, just pay them. They'll be paid once a month if they achieve their goal or whatever. This has taken off. Much like biomarkers in medicine, the notion of behavioral modifications to get people to adopt or change, either adopt healthy behaviors or change unhealthy behaviors, has taken off. It's particularly popular in employer-based health plans. Insurers are beginning to use it. But I noticed in the legislation that passed in Congress, the healthcare reform, the Affordable Care Act last year, that passed Congress last year, that there is language in there to allow for the adoption of and testing of these kind of interventions. And I think we're going to see more of these. And I think one great challenge for for desktop medicine will be how to have physicians adopt this into their practice and use it. Because it introduces a somewhat unusual feature into the doctor-patient encounter, namely putting incentives in place for achieving behaviors. As I say, to date, this has been largely discussed in the context of employer-based health plans, work-based things, but it's beginning to enter the clinic, and certainly for people over 65, some of the largest consumers of healthcare, where employer-based mechanisms aren't very feasible, we're going to have to start to think about how we're going to adopt these into our clinical practice. Can't rely on employers to do it. So, consequences of desktop medicine for treatment. Well, physicians are going to need to learn how to make their patients, quote, feel their risk or appreciate their risk. In other words, it's all very well to understand it. You told me my risk is X. What we want people to do is say, and I think my risk is X. The problem is when they say, you told me my risk is X, but I think my risk is X minus Y. And that's why I am or am not doing these certain things. That's a big challenge. Physicians need to be more comfortable with the mechanisms that, frankly, manipulate behavior, including seemingly non-medical approaches such as payment for adherence. The desktop medicine article came out in JAMA and got a bit of pickup. I got a fair number of emails, a couple calls from a variety of media outlets. And one of my staff members showed me this. This is from a blog spot on the web that they found. Desktop medicine stands to dramatically transform healthcare towards an era of risk identification and disease prevention, according to a commentary appearing in the Journal of the American Medical Association, 10 November 2010. And here we see a doctor at his desktop there. You see the desktop, you see the computer, practicing desktop medicine. Just tell me to enter, let me just enter a few details into the computer. Click, 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 click. You see the doctor working there. Tap, 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 tap. Hit submit. Well, the good news is that your cardiovascular disease risk is very low. Unfortunately, it would appear that you're moderate to high risk of being a clown. We'll recheck in 3 months. Meanwhile, it may be prudent to modify your risk factors. Use less face paint. Wear a larger hat. More appropriate footwear. Any questions, Mr. Bozo? Would you like to sniff my flower? And there it is. The end. I put this in here because this is a new model of medicine, and it will be very interesting to see as patients and society begins to engage it, how they respond to it. Let me have some closing thoughts there on desktop medicine and the electronic medical record. The electronic medical record is as essential, I think, to desktop medicine as the hospital-based laboratory was to bedside medicine. You needed the hospital-based laboratory to discover, to diagnose, to treat, and to track diseases. I mean, I remember going to the lab in the hospital to look at the blood culture results, to look at the smears, to look at the urine. And I could argue today that we should still be doing that sometimes, and I'm not going to go on to that issue. But no one argued it that by the early part of the 20th century that a hospital meant it had a hospital-based laboratory. I would argue that the same logic applies to desktop diseases and their treatment, and that meaning the need for the electronic medical record. I do think, though, the electronic medical record is an incomplete term. The better term is the electronic medical database, or the EMDB. Because the EMDB really captures the fact that you just don't want a bunch of stuff scanned in and whatnot. You want data. You want data that you can look at, that you can chart, that you can study, that you can fuse together with other people's data. I would point out, though, I think that the more that the EMDB is national and public and not local and private, the more it will serve scientific interests. I do think that the conjoining of the electronic medical database with financial incentives to use it created what could be called a potential conflict of interest. In other words, the more I click on the more things, the more I get a level of billing that is more rewarding, I think is something we need to start thinking about candidly. That there's an incentive to do more documentation for the simple reason of getting to a level that might get you more money. We have to start talking about that, thinking about that. I'll leave you at this point. I think the history of the last half of the 20th century was the history of big pharma. But I think one of the things we're learning now is that drugs are, for as long as their patents remain, But the databases and technologies, well, those things are forever. And I think we're entering an era now of whoever controls the databases and the technology that create those databases and create the access to data and shape the data, whoever controls FRACS, whoever controls NCEP, whoever controls the data that goes into those things, they control what is medicine. That's the end of my formal remarks. Again, if anyone has any questions, I think now we're going to enter into a time of questions. I know that Dr. Nace had to sign off early to catch a flight because of some schedule conflicts that were created. But I think someone else will be handling the moderating of the questions. Also, I have my email here if anyone who's interested in writing. That's another way to reach me. And that's the end of my formal remarks. Thank you all so much for joining me. I realize it's a little awkward, perhaps. Certainly, I haven't seen any of you, but there's a lot of you there I can see out there listening. So I enjoyed it. Thank you.
Great. This is Chris Norton, and the Executive Director for the Center. And thank you very much, Dr. Karlowish. That was some wonderful food for thought about the truly transformational and cultural shift that we have to go through to fully embrace the notion of disease as a risk and to integrate that into some of our other medical home principles like evidence-based medicine and clinical decision support tools. I would like to remind the audience, if you have questions, to go over to the right-hand side of your screen and the drop-down spot for questions and enter them in. We've muted the line so that we're not taking questions verbally, but you do have an opportunity to present your questions in writing, and we'll start to go through them and present them to Jason for his thoughts. Dr. Karlowish, one of the first questions that came in is that the new paradigm that you have mentioned is well recognized by all of us in clinical practice, but it really doesn't translate very well into the 20-minute visit that we have with our patients with chronic diseases. And with 20 MDs reviewing data with patients with high literacy, it often takes a long time to get through the encounter, and that this time spent is often not reimbursed. Your thoughts?
I agree.
Right.
Again, I agree. And the opening remark I made was that I think a lot of the discussion about ways we should change the structure and process of a medical encounter have been kind of small beer debates that have been largely around kind of money issues. Not that money isn't important. In fact, it's probably the ultimate driver. My modest argument here that I'm making is that when models of disease change substantively such that medicine changes, you really need to be open to, frankly, I'll use a word that you want to be careful using, but radical revisions to the way you structure healthcare. Imagine all of a sudden if we adopted a model of disease that was based on spirits that did or didn't possess people. And we all believe that that really is what is disease. Well, we would very rapidly want to radically change how we train doctors and set up the practice for doctors so that they could understand, which spirits possess which people in which ways and what kind of setting they need to do to practice that medicine. I know that's a bit of an odd and somewhat cheeky analogy, but I think in some sense what's happened in medicine is as similar as in desktop medicine is as similar to that.
Great, thanks. Good reflection there. My next question really kind of plays off the cartoon that you presented at the end with the doctor-patient encounter and the terminal in the office. And as an ethicist, you probably have some concerns about the encroachment of IT tools into the doctor-patient encounter. How can we really best preserve the sanctity of the doctor-patient relationship without undue intrusion from activities like data input?
Yeah, it's a big issue. I don't pretend here to have the answer to that, but I've read some other essays by colleagues, for example, how in the inpatient setting, essentially all everyone's doing is spending their time sitting in front of computers. I've witnessed how the house staff, I practiced in a house staff intensive program, but are sort of copying templates and ticking on the templates and spend more time, it seems, copying and using templates than they are sort of thoughtfully writing a note or actually going and talking with and examining the patient. I think that So this is a pitch maybe to our friend. I'm not saying we should throw out the electronic medical record, but I do think we need to, here's a pitch to those people in the IT world, think more carefully and creatively about, what are the kinds of computers that we need to be able to practice medicine. Who were computers designed for and what were they designed to do? Well, they were not designed with the idea of how to help a doctor practice medicine. They were designed for, how to have, in the early years, how the guys that founded Microsoft could have fun in their garages. But, later on it was, for desktop fields that, dealt with numbers and didn't have to deal with interacting with an individual. I'm not trying to put a technologic fix to a technologic problem, but it sounds like what I'm doing. But I do think that it's disturbing that many people complain that, I go to see my doctor and they just stare at the computer screen all day and don't really look at me and talk to me. On the other hand, though, I can understand the other side of that, which is I got to get this data entered. So I agree, we have a problem, and we need to solve it.
Yep, great. The next question I think really gets to the heart of the matter of your presentation, and how can we get the physicians that currently practice medicine in the old school of thought of bedside to start thinking about desktop medicine, preventive medicine rather than reactive medicine? And your thoughts?
Yeah, a couple things. First, I do think the concepts of disease as risk and treatment as risk management have really infused a good deal of medicine. So I think, and I do think it represents a kind of epistemologic shift in the way doctors think about the facts. I use the word epistemology because it's the best word I can think of. If I spent more time, I could come up with an easier word, I think. But essentially, it's the science, the philosophy of knowledge, what counts as a fact. And I think physicians in general are more increasingly comfortable with the notion of thinking about, disease as risk and treatment as risk reduction. Whether that's taking care of classic desktop diseases like high blood pressure, or taking care of very symptomatic diseases that might need a very bedside intervention like surgery. I mentioned earlier in the course of my remarks that if you look at the surgical textbooks of the last several years, you see the rise of thinking about surgical risk as a way to organize and govern the way a surgeon thinks about who to operate on and how to operate on them. And there's a field that you might think is sort of separate from or not at all engaged in, if you will, desktop medicine. So in some sense, I think that time's on the side of that way of thinking. To the extent that that's true, I think we need to be we need to open our minds to then who do we need to be admitting into med school and how should they be being trained and in the course of med school. And I think that the kind of hostility that medicine has had, and I can understand the hostility it's had towards statistics, needs to be revisited, rethought. I remember, and you can still find letters to the editor and essays where people say, I don't take care of averages, I take care of patients. And yet my response to that is that the only way you understand your particular patient is because you understand the averages. There's something going on there that's sort of fundamental in the kind of, if you will, the sort of, the epistemology of those two sides. I think, though, we have to start to worry, though, about how that way of thinking, what does it create as an opportunity, but also what does it create as, if you will, a downside. That way of thinking, for example, in the financial world, that is to say, thinking about risk in an actuarial way, led the financial world into sort of near to disaster in the last 10 years. Obviously, our issues are different. We don't invest in our patients and whatnot. But the more we start thinking about disease as kind of an actuarial problem and, tweaking the risk, the more we can make dramatic and sometimes potentially catastrophic changes in what we say is disease and who we say should be treated. So that's an area that we really need to start sort of thinking about. I'm wondering if I know off the topic of the question. Let me circle back. I do think another way that can help doctors to better adopt this desktop model is the use of the electronic record. And I think it has both strengths and weaknesses. I personally have gone from a paper to an electronic medical record fairly recently. And it's interesting. I just was enjoying the training, actually, the scientist in me, the researcher, because I was sort of thinking, this is desktop medicine. Look at how, I can chart out these patients' results. Look at the way data is so much more accessible to me. Look at how someone who aggregates these data across multiple providers and patients could start to look at trends and identify new things. And I was fascinated. And certainly, anyone that's forced to, frankly, adopt that kind of record is going to essentially be kind of shoved into a desktop model. I was also sort of intrigued that, both what it opens up but also what it constrains. The electronic medical record has its smart phrases and other shortcuts. It starts to control the language that you can use and the way you can use it and represent it. I'm not pining for the days of chart notes written with fountain pens, on unlined paper, but, and I'm not sure what I'm pining for, because I can understand the logic of smart phrases and all the other techniques that allow the charting to be efficient. But I think we have to recognize that if the only goal of the physician's interaction with the electronic medical record is efficiency, we will certainly be trading something off for that. You cannot maximize efficiency without trading something else off. And, the EMR is a relatively new entity, or EMDB as I like to call it, and I think we should respect that it's not a passive piece of technology. It changes the way we think and the way we talk to each other. And, again, I'm not an informatics scientist, but I hope some informatics scientist embraces that as an area of his or her research, because I think that if we don't think about that scientifically, I'm concerned that other forces will think about it and shape it towards their goals and ends, not towards the scientific goals and ends of practicing good desktop medicine. I know I packed a lot into that, but it's an important question, as you actually pointed out. So.
Multivariate, yeah. The next question actually follows on very nicely to your comments, and how can we best utilize electronic health records with patient access in order to integrate this information? Any further thoughts there?
Yeah, boy, this is like a new area for me too, so I'm going to probably, I think many people listening to me could probably answer that better than I could, except to say that, and in the essay I didn't mention it at all, I had to cut it out, and in the talk I didn't mention it at all. But yeah, I mean, we're fooling ourselves if we think we're going to have unilateral control over the electronic medical database. And, we're fooling ourselves if we think we're going to have control over the flow of information in the patient encounter now. And, again, I think the opportunities for research in these areas to develop best practices are huge, ripe, ample, and desperately in need of study. So let me talk to that, because that's something I can relate to as a researcher. What institute at NIH would you apply to get a grant to study that? Who would fund your K award to look into that? Well, there's ARC or whatever it's called now, but we need to have the same kind of attention to solid scientific study of these issues as we do to identifying the biomarkers of disease or all the other things that are very important and need to be funded. But, we're fooling ourselves, I'm repeating my remark from the beginning of the answer, if we don't think that the trend is that patients are going to now have more access to control over of this information, and how that can change and transform the doctor-patient relationship, we need to start thinking about very carefully.
Great. This next question may be a little bit above and beyond your remarks, but see if you want to tackle it. And have you defined the information exchange specifications when using the EMR or EMDB? There's still confusion as to what health plans want and what providers need in return.
I don't quite get the question, but I think so. But I am very bothered by the Tower of Babel across, between, and among EMDBs. I don't think that's exactly what the question was getting at, but in my own health system, we have a separate record for inpatient and outpatient, and, if there was one magic wand to wave, it would be, can we all have the same language? Now, I think I said the word Tower of Babel because I think the reason why that story is in the Bible is to emphasize the notion that we could all speak the same language is folly. We use different words to mean the same thing, and we use the same words to mean different things long before we ever had computers. But, the rise of the EMDB, I think only unfortunately amplifies the chance of, the inability to cross-talk and understand what other people are saying. I think the problem, of course, is that when you have diseases that are fundamentally actuarial diseases, going back to the early 20th century, the insurance companies discovered these things because they had and they knew they needed big databases to describe what's the chance that a 50-year-old guy who walks into the office and smokes, is worth writing a policy for. They knew they needed those data, and they got that data. we need those same kind of data, if you will, on a national basis, so we can take care of, so we could, for not to write policies on people, but to understand the diseases they have. And so I applaud the national effort to create a national medical record. I'm not going to comment on more on that, except to say that the more it's thought of as a national medical database, the better. I would not want to be the one in charge of trying to do that in light of both the local and private efforts that have been done, but greater minds than I will work on that.
Great, thanks. We still have time for one or two more questions, so I'll pause just a moment if anyone else has other questions they'd like to submit. I would like to, again, remind everyone about our upcoming April 14th webinar with Dr. Roger Kessler from Fletcher Allen in Vermont, speaking about a behavioral health HIT integration project with their medical home endeavors. And check to see if we have any additional questions. We have one comment that I'll forward to you, Dr. Karlowish, and you can respond to the writer individually. And looks like we're probably about at a close, and I'd very much like to thank you again for your candor today. Dr. Karlowish has been a wonderfully provocative and dissertation about things that we really need to be thinking a little bit more deeply about in terms of culture. And thank you again for taking the time out of your busy schedule to be with us today, and appreciate it.
You're very welcome. I greatly enjoyed it, and I appreciate everyone who listened and their questions. Thank you very much.
Great, thanks. Okay, we are at a close, and hope to see many of you again on April 14th. If you particularly enjoyed the presentation today, it will be online in about 1 week, and you'll be able to download it as a podcast and also review the slides and refer any of your colleagues to the presentation if you would like to share that with them as well. So thank you, and look forward to talking with you all again soon.